Everyone, welcome to round 8 of Disrupting Kidney Care, where we discuss all new trends and topics in kidney care. I'm your host, Dr. Qasim Butt. I'm both a clinical and interventional nephrologist for around 15 years, and I'm excited to have y'all here. This is a live webinar, y'all, so do me a huge favor, hit up that like and share button just to get it out to more people on LinkedIn. Also, if you're watching right now, go into that comment section, tell me who you are and what's your relationship to kidney care. Are you a doctor, a nurse, a patient, a clinic administrator? Let us know in that comment section, okay? And we're about to have a live Q&A afterwards, so please hold those questions till the end. But if you're willing to, if you want to, go ahead, put them in there as we're talking as well too. Now, on this webinar, we have discussed topics of value-based care, medical technology, patient advocacy, and we've had guests on that are physicians, entrepreneurs, and even authors. And today's panel will not disappoint. Now, over the years, I've had the opportunity to get involved in medical innovation. And what I've begun to realize is that not all innovation is what you think it is, right? Oftentimes people want innovation to be that shiny new objects, something that has a lot of bells and whistles, right? Now, innovation doesn't have to be a new medical device. It doesn't have to be artificial intelligence. It doesn't have to be a new pharmaceutical. Sometimes innovation is just a new way of thinking or a new way of approaching patient care, a new way of thinking about patients and how they feel, right, and how they're doing. Now, one of the biggest problems I've seen in kidney care, and one of the biggest deficiencies I've seen in kidney care and medicine as a whole, is that lack of communication that we have with patients about their understandings and their wishes. This is particularly the case and the most consequential in the last few moments of life. Today's topic is dialysis and end of life. Now, end of life is not a topic most people, patients or doctors, even want to talk about, right? It can be very difficult. It's a very intimate topic. Well, today's panelists have come up with a new way, a very innovative way of discussing end of life and treating end of life. It's called concurrent dialysis, and they're going to go into that with you. Now, let me go ahead at this point. Go ahead, bring up those panelists for you, okay? First up, let's see here. First up, we have the man, the myth, the legend, one of the nicest nephrologists you will ever meet. Okay, this is from Nashville, Tennessee, the CMO of DCI, Dr. Robert Taylor. Dr. Robert Taylor, come on up.
Oh, Qasim, can you hear me?
There you go. How are you doing, man?
Doing great. My mom should be on. She should be hearing this.
Yep. You are. I'm not joking. You're one of the nicest, pleasantest nephrologists I ever met. If I had kidney disease, sir, I'd want you there. So.
You're very kind. You're very kind. Yeah. Thank you. Well, good evening, everyone. Qasim, thank you so much for inviting us. I'm so excited to participate on this discussion. So for everyone out there, my name is Robert Taylor. I'm a practicing nephrologist in Nashville, Tennessee. I'm CMO of DCI. I am one of the co-founders of Reach Kidney Care. And I have really had a great opportunity to work with Jane for years in developing the concurrent model. And I look forward to the discussion and the Q&A. Thanks, Qasim.
Sure. And you're still practicing, Robert? Really?
I do. I still practice.
That's amazing. To be a chief medical officer and still practice, that's pretty amazing. Okay. Yeah. Next up, you brought your partner in crime, right? So let's see here. Next up, we got a woman here who apparently just loves taking board exams because she has completed a residency in internal medicine, a fellowship in nephrology, and a fellowship in hospice and palliative care medicine. Please welcome from UPMC, the section chief of palliative care and hospice, Dr. Jane Schell. Let me see here, Jane. Let me bring you up. Hello, Jane. How's it going?
It's good. Thank you so much for having me. And I couldn't have a better co-pilot than Robert Taylor. So I'm excited to be here. I'm excited that you're framing this discussion around innovation because we're right there with you. We actually believe this is a better way of caring for patients. So my name is Jane Schell. I am a practicing palliative care physician and nephrologist. I am a medical director of a dialysis clinic, and I provide dialysis care. I'm also the section chief at UPMC, and I have the joy and great passion to be the palliative care advisor for DCI. So thank you for having me, and looking forward to a great conversation.
Awesome. Awesome. Now, when I approached both Robert and Jane about this topic, they said we can't do this topic without a patient advocate or a family advocate. And so we actually have a terrific woman here. She is a woman whose mother went through the concurrent dialysis program with UPMC, and she speaks really highly of you. I'm going to bring her up right now, Mrs. Beth Crawford. Hello, how are you doing?
Hello, how are you? Thank you for the invite, and I am honored to be on such an esteemed panel. I am very fond of Jane and Robert because of the work that they do. They were my angels, and I would say one of the most challenging times of my life. So my name is Beth Crawford. In my spare time, I like to represent the patients and the families for the concurrent care program, which is a program that is second to none. We have to get the word out. It needs to be a national program because it is definitely something that is needed for the patients going through the ending stages of renal failure and the support for the families.
Absolutely. And right behind you is a picture of your mom, right?
Yes, that is a picture of my lovely mother and my father. And that's why I put it up tonight, because every time I speak, I do it in honor of her, Gwendolyn Crawford, and I am just keeping her legacy alive.
Awesome. Awesome. And I know we talked about what you went through and everything. And I honestly was kind of like taken aback at how amazing it was as a process for you guys. So let's just go ahead and start the conversation. Right. And I'm going to direct this question to you, Jane. So just to put this all in perspective of what patients go through, where do most dialysis patients end up in the last few moments of their life?
Yeah, I think it's really important to talk about what the usual end-of-life experience is for patients on dialysis, because that's why we created Concurrent. Most patients that are on dialysis in the last month of their life, it is spent in a hospital. So 76% of patients receiving dialysis have a hospitalization in the last month of life. And half of those patients, almost half of them, will actually die in the hospital. And so continuing to sort of go after medical interventions or what is coming their way, they sort of just continue moving forward until end of life comes. And, for those patients, some of them get hospice. In the general Medicare population, about half of deceased Medicare beneficiaries receive hospice services. But when you look at the ESRD, which is the end-stage kidney disease population, that number is about 20%. And so it's less than half of what the general population receives.
Wow. So only 20% of patients on dialysis receive hospice. Is that right?
That's right. And what is also important is to think about, well, what does hospice look like for those patients? About half, so roughly 40% of those patients who do receive hospice, they only receive it for a few days or less. And when we think about like the robust, what is hospice? How does it help patients and families? It is a Medicare benefit that is really intended to provide whole person, whole family care for up to 6 months, right? When we believe that someone has 6 months or less of life. And so for patients to receive 3 or less days of hospice, they're really not getting the full benefit.
That's not, yeah. So how's about this, just for the audience, because I think we have a lot of maybe even patients here. Can we go over some basic definitions so that people understand what they are? So hospice versus palliative care, what's the difference there? I know you do both, but like, what is the difference there, and who qualifies for that kind of stuff typically?
Right. Well, and to start with palliative care is really a philosophy of care. It is rather than treating the disease itself, you're treating the whole person and some of the symptoms, some of the complications that come from that disease. A person can be receiving palliative care and receiving any kind of treatment, including life-prolonging treatment, chemotherapy, a transplant. They benefit from that service. And it comes in a variety of ways. There is palliative care doctors out like me out there in the world that might see patients in a hospital. I might see a patient in a clinic. There's also home palliative care programs that are usually dependent on insurance providers, and it can look differently. Now, hospice is a Medicare benefit. And so it has certain criteria. Its aim is really to focus on comfort care. It is when a patient's condition has gotten to an advanced degree when you could say to yourself, I wouldn't be surprised if this patient died within 6 months.
Is that a criteria, by the way? Is the 6-month thing a criteria or is it not? Go ahead.
It is a criteria, and there's also usually disease-specific prognostic factors that patient also has to have. So you have to qualify for hospice, and that usually requires looking at those criteria and then having a physician who actually certifies them for hospice services.
Okay. And that's more about making you comfortable, right? That's like the pain medications and all that kind of stuff, right? That's what it entails typically versus palliative care. Go ahead.
Correct. And there's a piece of that symptom management. I think the other parts of hospice is that it is interdisciplinary. It really brings care to the home. And it does everything by medications, by durable medical equipment, by staff to keep that person comfortable, living the best quality of life possible for the days that they have. And that's usually in a home-like environment.
Okay. Let's go into some other definitions real quick. DNR. What's a DNR?
Yeah, so a DNR is an order that someone has determined that when they reach a state in which they are facing end of life or a cardiopulmonary arrest, they do not wish to have intensive interventions like CPR. So it is usually an order. It can also be in a living will or an advance directive, so legal guidance. And then there are also medical orders that physicians, providers can complete with patients that also outline those wishes.
Now a DNR has to be reestablished when they come to the hospital. Is that right? So DNR stand out of the hospital, but when you get in the hospital, you have to reestablish them. Is that correct?
In general, you revisit code status every time a patient comes in. And that gets hard, Kasim, because, if people keep getting asked the same question over and over again, they start to wonder, did I give the wrong answer?
Yeah.
We actually, at UPMC, we do a lot of education around how to have second conversations with patients once they have had established code statuses, DNR, a living will, a POLST.
And I feel like a lot of these conversations just need to be had among so many people. Like, I almost feel like everyone needs an advance directive on paper, right? Like just what they, and at any age, and the goalposts change, right? So I have advance directives currently, but I'm in my 40s. When I'm 60, I need different advance directives. When I'm 70, I need it. And I don't think anyone revisits them like they should, right? Like,
right.
So go ahead.
I think that's the reason you do need to periodically revisit those conversations, because life changes, right? Your experiences informs how you look at your values, how you make decisions. And so, yeah, we do need to update them. How I feel now is definitely going to be different than how I feel 40 years from now. Hopefully
I can even imagine how you feel at the beginning of when you start dialysis and how you feel 4 years into dialysis is a completely different scenario, right? Beth, I'm just curious, like all these terminologies that we just threw, DNR, advanced directives, palliative care. Were you familiar with them at all before your mom started dialysis?
Yes, I was. Unfortunately, my mom had some very prolonged health challenges. So I was her medical power of attorney, and also outside of medical, I was just her POA in general. And then we had the DNR, especially when she went into dialysis. But one of the really benefits of the concurrent care program was at intake. Any terminology that we were unsure of, Jane and her staff they broke it down into layman's terms and easy for us to understand at the time of intake. And our intake appointment was over 2 sessions. So, I mean, that's the beautiful thing about what Jane and her team of nurses and medical assistants do, and social workers. They make they bring the realization of the critical nature of the situation, but they ask you about these things. Do you have these things in order? They give you the opportunity to deal with reality with hope for a miracle, which to me is so important. And if there was something that I didn't understand, or if my mother did not understand it, they made sure before we left that appointment, we understood what we were dealing with and what we needed to do.
And Robert, like, interesting enough, like, I find that this conversation, because this is like, you have the ideal family advocate and you have the ideal clinic with this stuff, but most of our dialysis units aren't like this, right? Every time I bring up like a DNR or like advanced directives in a dialysis unit, no one knows how to even approach it. Is that something you guys are kind of working on at DCI now, or is that something still a bit of a problem? Go ahead.
It is. I think you bring up a great point, and that is, how do you scale this? I mean, if you've got someone like Jane and Beth and that type of nucleus, then of course you're going to be able to launch this type of program. How do you scale it? And so when we started to move the concurrent model out of UPMC, say the Middle Tennessee, it's part of our CKCC model. We had to spend a lot of time identifying a hospice advocate, identifying a nephrology advocate, and then educating our dialysis staff and our administrative staff about, this is what concurrent care is. And it's okay in this circumstance not to approach dialysis in such a regimented way. And I think as nephrologists, we know that at times, some of the criteria, especially the quality criteria, they require us to approach dialysis in a fairly dogmatic way. So one thing we created early on, I think, is one of the most important things that really helped us move forward, was creating palliative dialysis, both PD and hemodialysis order sets, which really started to put structure around, it's okay to do this. It's okay to take a different approach, but you have to continue to educate, to draw in the clinic staff, the administrative staff, and physicians.
Yeah, one of the biggest problems I have with nephrology as a whole, in particular dialysis units, I feel like most dialysis units have an assembly line rope mentality when it comes to patients. That's regarding dry weight, that's regarding anemia management, that's regarding KT/V, that's regarding fistula access placements, catheter placements, all this kind of stuff. And I'm like, sometimes you have to be somewhat unique and have more personalized care for individuals, right?
I think so. And it goes back to where you started. It's innovation. One thing, and Jane and Beth can speak to this even better than I can, you have to be interested in a patient's goals of care. What's important to them? How do we meet you where you are and really provide for your needs? And I think your point's well taken, Qasim, that we have moved away from that at times. And the thing as a nephrologist I've really loved is bringing that back into focus, making sure that as best we can, we're putting the patient and the family at the center of care.
Yeah, absolutely. And, I brought this up earlier in our side conversation, but literally yesterday, I had a patient in clinic, in my CKD clinic. I inherited from another doctor, 78 years old, had a fistula in her arm, mature, ready to go. No one asked the lady if she actually wanted dialysis. No one asked her. And I was like, no one asked you? And, she literally said she didn't want it. And her daughter was right there and she was surprised, And so I think a lot of times we just caught up in, this is the next step. We're CKD4, we're CKD5, put the access in, start dialysis when the GFR hits whatever, and that's it, and we never step back and go, hey, this is what's the next step. This is what the patient actually wants, right?
I agree. And I think, Jane, I'd love to hear what you have to say. It's one of the beautiful things of nephrology is you get a chance to know the patients and the families well. And part of our mandate as providers, as people who care for patients and families, I believe should be that we as well as we care for them as they move through the process from CKD to transplant to potentially dialysis, that we walk gracefully to the grave with our patients. They have entrusted us with that care. And so it is, for me, I think, and for the team, it's a calling to make sure that you do that well. Jane, I'd love to hear what you have to say.
Yeah, I think this is such a great conversation. And one of the reasons we built, and I know we haven't really defined what concurrent care is. When I started at the beginning naming the little amount of hospice that our dialysis patients have access to, we see that a major limitation to hospice for dialysis patients is really the hospice Medicare benefit. What it says is that if your hospice diagnosis is related to your kidney diagnosis, and it actually becomes very hard to unrelate the two, then the dialysis is not paid for within that hospice benefit. And it's expensive. And so hospices will often say, yes, we'd love to take you on service. We'd love to provide comfort, and you'll have to stop dialysis. And we all know that would mean time would be quite short. It would be days. And so patients often don't choose hospice until, if they do get access, it's at the very end of life. And I think that's where our innovation came from, was like, how could we change this? And what we did was basically say, dialysis can be part of end of life, and it can help patients achieve their goals for the time that they have remaining. And so we created Concurrent, which basically is using dialysis as part of the hospice care. And so with the partnership between DCI and our UPMC Family Hospice, we created the program and kind of named that patients who would have goals that were comfort focused and still wanted to access dialysis, is that we would provide that dialysis. We would provide it in a limited way, in a way that was really tailored to the patient's needs, their goals, and their symptoms, and provide hospice alongside. And that was the creation of the Concurrent program. And
so oh no, go ahead. Please go ahead.
No. And we created it about 6 years ago. So we've been ongoing for 6 years.
That's amazing. And so, like, with the concurrent dialysis, you're not having to do a 4-hour treatment on dialysis, right? You're not having to do it 3 times a week necessarily, right? You're not having to meet metrics like KT over V and anemia and PTH and phosphorus and all that, I imagine, right?
We shift the whole philosophy, the whole what we are doing with dialysis, to think about, what does this patient before me need? And I think, in addition to thinking about, probably 3 times a week, they probably don't need that anymore, nor do they want that. They want to be having good times with their families. So we often will take it to twice a week, and we give them choice. So we allow them to say if they want to come or they don't want to come. And that really actually changes the paradigm a little bit, where patients actually get to be involved in their care. Rather than being told they can have this, not have this, they have a say. We also think about the time. Do they need 3.5 hours? Do they need 3 hours? We also don't check labs that aren't going to provide benefit to the patient. Those kidney medications that you talk about, like vitamin D analogs, even anemia medicines, at that point for these patients, those medications aren't adding comfort. They're more so adding expense and more lab draws. The whole team really focuses on, this is a concurrent patient. We liberalize diets. We look at medications, and we make
that's awesome. I hate the renal diet. I would never want to be on it. I every time I hear a dietitian explain it, I'm like, that sucks. Like, I would never want to be on that diet. And especially in my last moments of life, let me have that steak. Let me have that glass of milk. Let me have that orange juice, let me have it. But yeah, again, go ahead. Sorry.
Yeah, I mean, and I think that creating the concurrent program, we have served patients, we have served families. I think the other benefit we've seen is that the dialysis team feels empowered. We all have cared for declining patients, right? And what the dialysis team does now in the current setting is we just got to get them through this treatment. We got to get them through this treatment. Now they can step back and say, hey, wait a minute. I think I have another path option that you might be interested in. And they can offer something that they really believe helps patients.
So how do you identify that patient, right? Say me and Robert or whoever is rounding, right? How do you identify a patient that you're like, hey, it's time for palliative care or maybe concurrent dialysis? How do you identify that patient? And Beth, to your point, when did you know your mom needed to go on palliative care and hospice and stuff?
I'll let Beth start.
Okay, well, I can tell you, it was definitely the physicians and her numbers, because her kidney function had gotten to the point, I believe it was something like, if it was 20%, and it was decreasing. So when her levels got to the point where, like I said, we had to deal with the reality and just keeping in mind, we're hoping for a miracle. But when the levels got to the point where it just seemed like the inevitable was going to happen, and that's when they referred us to the concurrent care program. And I just want to say, with the concurrent care program, it is definitely a program where it is patient-centered. And the focus on the patient care is centered around what is the wishes, what is the desires of the patients. I heard Robert say calling. Everyone that we interacted with, you could tell they were called and they were committed to this mission. And never once did we feel like we were being a burden or we were being pushed through a system that was a cookie cutter system or a system that was just a system replicated. It was an individualized care plan. And in my line of work, we call them ISPs, individualized service plan. And I am telling you, from day one, Jane and her team came in and they became our extended family. And every description that they said they do as far as for the patients, because when it got to the point where it was compromising my mom's quality of life, because that was important to her, Jane gave me a gentle reminder, because that's a very difficult time when you're seeing your parent and this matriarch who was very vocal, very independent, and liked to live in a very dignified manner. And she was very vocal about what she wanted. They made sure that we kept her wishes at the forefront of every decision that was made. Even when I may have started to be a little selfish in my decision making because I wanted my mom to stay around, they reminded me of what she said she wanted. And I'll never forget, it was getting near the end, and Jane called me. It was in the evening. It probably was like 8 o'clock in the evening. It was time for her to be home with her family. And she said to me, she said, Beth, I think we're getting to the point where dialysis is prolonging your mom's suffering. Rather than giving her the quality of life, I think it's time for us to remove dialysis. I mean, that was a hard pill for me to swallow, but she was absolutely correct. She stayed on the phone with me. She let me cry a little bit, but that was what my mom said she wanted. Quality over the quantity of life. And when I heard those statistics, 76% of the patients die in the hospital, that wasn't Gwendolyn's story. Because of the concurrent care program, everything she said she wanted until she took her last breath, she got it.
Well, that means she had a dignified death, right?
Yes,
that's
she
something
did.
I think we
very dignified.
That's what we want. Robert, I'm going to ask you a blunt question. Do you think most nephrologists are actually comfortable with an end of life discussion with the patient?
I don't think so. I don't think it's something we're trained in. We are kind of uniquely pull towards a life-sustaining treatment. And as I've been in practice and I've worked with nephrologists over time, I just don't think it's a conversation that we're good at holding. And Jane may feel differently, but it's for lack of a better way of saying it commonly is not our gift.
Well, I'm surprised that, I remember being in ICU one day and listening to a hospitalist explain DNR to a patient on a dying family's family, dying patient's family. And I was just taken aback at how bad that explanation was one time. And I'm like, this patient's family is dying right now, and you're not giving the best explanation of what DNR even means. And so, and even for an educated, college educated person to understand what an intubation is, or CPR entails, or what, pressors are and all this other stuff, it's really difficult. And I just noticed that across the board with a lot of doctors. Maybe we're not trained in it, but it's like, but at the same time, it's a conversation I think we all need to learn to some degree, right? You're dealing with end of life kind of people, right? Dialysis people are not people that are going to necessarily get better. So it's something we need to be able to have that discussion on, right?
Agree. Could not agree more. I think it's, I think there are great opportunities to work with people like Jane. She does have programs where she teaches residents how to have these discussions. I would like to see it more incorporated into training programs. But I do think that when you look at how our patients die, it clearly indicates that we're not having the types of discussions we need to have.
Yeah. And even from the patient side, Beth, I'm sorry, but you're an exception. Like, you're a great exception. But like a lot of patients, what I've realized is I've tried to have those conversations with those 75-year-olds saying, do you want dialysis? Don't you? I don't know. They don't want to have that conversation. And I'll have them bring in family members, and they still don't want to give me their explicit wishes for whatever reason. And I think a lot of patients are just scared of death and scared of that inevitability. Right. And so, and they don't, is that your case when you've talked to other patients or other family members by any chance?
Well, in our family, I would say I have to agree with you. We are the exception, but we also have had some unfortunate medical challenges. So having a family that has dealt with breast cancer quite frequently in women who are in their mid-40s, it helps you face the reality, like I said earlier, reality with hope for a miracle. So those are conversations like making sure that people have their life insurance intact, making sure that we understand if you want a DNR and at what point do you want us to keep you alive. Those are conversations in our family that we have, and we have them, I want to say sooner rather than later. And it's just because of first of all, being a family of faith. We believe in, we'll have a better life after this life. And then also just having to deal with unfortunate medical challenges early in life makes you face the reality that you never know what the future is going to hold you. So don't leave all of that burden on your family members. Tell them what you want, and we'll do it to the best of our ability. But also having this program, like the concurrent care program, and Robert and Jane, DCI, and then also just being in the concurrent care program, it really softens the blow for you to really make an informed choice.
Absolutely. And guys, if you're out there, please give us some questions in the comment section. We're about to get to those comments. I'm just going to rehash everything and just kind of summarize as far as what the current paradigm is. The current paradigm is, if we want to do hospice on a dialysis patient, the patient has to put the diagnosis of ESRD as the reason for hospice. And then at that point, hospice isn't started, but dialysis has to be stopped. Is that a correct assumption? Is that right?
Yeah, just a small tweak. I think even when the diagnosis for hospice is not ESRD, it's often related to the ESRD. So if it's heart failure, they'll still say it's related and they won't pay for the dialysis. So I'm just trying to emphasize that it's actually rare conditions when they say, hey, you could have hospice and dialysis. Like, for instance, a patient got pancreatic cancer and they've been on dialysis for 10 years. well, that's probably not related, and they would continue. Dialysis would be therefore paid for because it's unrelated.
Got it. But either way, they have to stop dialysis, right? And if they stop dialysis, we all know probably in about 10 days to 2 weeks, they'll slowly pass away, right? That's what we're saying. So we're at that point, it's kind of an abrupt stop. Concurrent care, concurrent dialysis allows you to extend that time over a long period of time, decreasing the frequency and amount of dialysis, taking away the extra pill burden, the extra dietary restrictions, all that kind of stuff, and kind of letting you wean off dialysis and kind of pass away at home kind of thing. Is that how the model typically works, right?
Correct, with getting hospice services alongside. Yeah.
Okay. And Robert, if you can go into the reimbursement scheme here. So the concurrent dialysis, is that a reality right now in Medicare to get reimbursed for concurrent dialysis?
Well, so in the CMMI demonstration model, the CKCC, they have a waiver that allows for a patient to receive concurrent care. In that setting, the hospice bills and is paid for routine hospice care. The dialysis organization bills and is paid for routine dialysis care. That is, at this point, something that's really restricted to the CKCC.
So only CKCC, only the CKCC,
yeah.
Not a Medicare Advantage plan, not traditional Medicare. It is strictly to someone in a CKCC. Okay.
That's right.
Okay. And so in that scheme, you were, as a dialysis unit, you'd be able to bill the regular dialysis sessions. If they did 2 treatments that week, you'd bill the 2 full treatments. Is that right?
Exactly. That's right. That's correct.
Okay. Yeah. And I know you and Jane went to Washington, right? To actually kind of lobby, I guess, do some lobbying. Is that the right term? I guess?
No, advocacy.
Advocacy,
We have been to the Hill multiple times. We had the opportunity to meet with Beth and Jane and MedPAC in Pittsburgh, and that was in 24. That was our second meeting with MedPAC. We've had discussions with leaders at CMS and really the CMMI team, emphasizing, as Jane pointed out, at this point, the majority of patients are not experiencing a good end of life when they're on dialysis. There can be relatively simple changes that can be made in policy that would allow a patient to receive both hospice and dialysis through the concurrent model. And I think quickly what we're seeing, just when a patient has the opportunity to participate in end-of-life care, when they're in the concurrent model, about 40%, once they know that they can participate and they meet the hospice team, they stop dialysis then. The other patients may continue. It's just the ability to have your goals of care recognized and to participate in the process. So it's these types of events, Cosmin, that you're holding. It's the meetings with On the Hill. It's with CMMI. It's with MedPAC. And it's sharing these stories. And Beth has been so eloquent. You can't overemphasize the impact of hearing patients and families talk about how this changed or this opportunity changed the outcome.
And from a value-based care perspective, this would decrease total cost of care. Like in a second, of course, the patient would pass away, but a lot of times I feel like we just dialyze people for the sake of dialysis, and we extend their lives without extending any quality at all. And so I can imagine someone going on this program passing away in a few weeks or few months, as opposed to living another 6 months or 8 months suffering, right, for no reason.
Right.
And so the total cost of care would actually probably go down. And honestly, I think a lot of patients would actually take you up just for the decreased frequency of dialysis, right? Like at that end of life when they're just feeling weak and tired all the time, they'd be like, yeah, I'll do that. That's awesome. I can imagine that.
I think, and Jane has more experience than really anybody I know, but it is that ability to participate in the process. And, I'll be honest, having participated in value-based models, for me, concurrent care sits at the perfect intersection of higher quality, a better end-of-life experience, so higher quality at lower total cost of care. And whenever you work with CMS, CMMI, any value-based model, that's one of the hallmarks. How do you provide better care at a lower cost? And for me, and I hope for Beth, and I believe for Jane, that's where concurrent sits, at that perfect intersection.
So we have Kimberly Lanford. She's asking a question. Do all facilities offer this? Now, we talked about the CKCC models doing this. So is this a DCI UPMC kind of exclusive thing, or are there other dialysis units, dialysis companies that are participating in it as well?
No, I definitely know through the CKCC that other dialysis organizations are participating. We have other hospice organizations other than Family Hospice and UPMC. We have Alive Hospice in Middle Tennessee, Hospice of the Valley in Alabama, University Hospice in Knoxville. So it really is connecting the dots between the model and finding a partner that's willing to work with you. And so, and most hospices I found, once they understand what you're doing, they typically are very excited that we have been looking for something like this. It's so nice to know it's out there, but it is not available to every dialysis unit. Not every hospice participates in it, but certainly other dialysis organizations do have concurrent care or at least are approaching better end-of-life care.
Mm-hmm. Michelle Hilton, she's asking, I guess this is a Jane question. How do you navigate Medicare's rules for funding hospice care in patients with renal related prognoses? I guess, do you just put the prognosis, so renal related, so you can still use a diagnosis of ESRD in this scenario, right?
Yeah, so I think it's really important. It's a great question. And it also allows us to emphasize how we started this program. So the way that we were able to provide dialysis alongside hospice was that it was through foundational money that paid for the dialysis itself. So DCI, Family Hospice at one time, they believed in this innovation.
Oh, wow.
And so that's where the dollars came from. Now, if you are in the CKCC and you have and you're participating and you have a patient that you want to do concurrent with, you would continue billing for dialysis and for hospice as well, because they have that benefit waiver.
Interesting, but I would imagine not all CKCCs are set up for this, right? I can imagine that they're still probably going to do the 3 times a week dialysis just because they don't have a program set up properly. Am I right or no?
Well, I think you're saying a couple things. If they're able to do hospice and dialysis, maybe the dialysis diagnosis is unrelated, or they're in a CKCC. Yeah, many programs haven't really, they may not have the concurrent order set. We have an actual order set that guides the nephrology team to dial down the dialysis, to think thoughtfully about the time, the ultrafiltration, how much fluid you're taking off. I think that piece of innovation is something that we've really been trying to develop. And actually what we've learned is concurrent is absolutely that we believe that is value-based end-of-life care for dialysis patients. But we recognize when we do this work really well, we're starting earlier. We are meeting these patients. We're starting to build that rapport, talk about, their end-of-life wishes or what they're hoping for. And we're often doing a bit of what we call palliative dialysis, which is those patient-centered dialysis that's starting to meet those needs of the patients while we're starting to have those really vital conversations. Ideally, concurrent is not a light switch. It's not like we walk in and we say, all right, it's time that we talk. Let's do this. It's often happening over time, and palliative dialysis allows us to start to bring the patient's goals into their treatments.
Interesting. And, I start to wonder, like what you're saying, how the whole CKCC thing is go upstream, right? With CKD 3A, 3B, but even in dialysis, go upstream a little bit. Don't wait till they're absolutely miserable to do hospice and palliative care. I think a lot of patients, and Beth can comment to this, but I think there's a point where a patient reaches, I'm ready. Like I've come to terms with my mortality and I'm okay to let go now. And if palliative care gets involved early, they can have a more dignified death towards that end, right? So
right, that is so true. And I always tell everyone I have the opportunity to talk to, the team at DCI and Jane and her staff, they operate with the 3 C's. They have a level of commitment to the patient's wishes, that is second to none. And it is documented. And then their communication, they communicate frequently. They make sure everything is on track, which is just so reassuring to the family watching their loved one, go through this life-ending change. And then just the level of concern and compassion, and how they handle the families that are going through this process in a delicate manner and nature. You can just really feel the genuine care, concern, and commitment to the patient's wishes of how they wanted to end their life. So, it's just phenomenal. And I wish everyone who is faced with this challenge, as far as the family members and the patients, had the opportunity to go through the concurrent care program, because it provided families with just the support in the social services realm too. So when you see that your loved one is declining, how do you deal with the psychological benefits? And also for the patient, just having that therapeutic intervention, dealing with the psychological aspect of it.
Well, to that point, Beth, real quick, we got to have someone here, Pesh Patel. He's actually a patient advocate and a friend of mine. He's actually asking the question, does the concurrent program offer a therapist for the patient as well too?
Yes, we receive it's a social worker. So, a licensed social worker who they came in and they met with my mother, as far as with her, and also with myself, and then we also had the grief support that came in upon her demise. And this was all through the concurrent care program, and we didn't have to pay for this. This program is so needed, because it really is the wings that helps the patient and the families glide through this very challenging process.
Yeah.
Go ahead, Jane, go ahead.
I just want to build on that for one moment. I think what Beth is describing is concurrent. It opens the door to bring in the full hospice interdisciplinary team. And so then you've got the hospice team working with the dialysis team, and that is really providing that really whole person care. So that's the benefit of having hospice in a timely way.
No, absolutely. Then there's let me see here, Josh Dubinsky. He's actually owner of a dialysis PD company, actually, and he offers PD services to a lot of patients. He actually says they do have some contracts already with some hospice agencies, I guess. And I think in that scenario with PD, you could just do a few exchanges a day, right? I imagine, right? Like maybe just go to like 2 or 3 manual exchanges a day or something like that, right, Robert? Or
that's correct. Yes, absolutely. Yeah, it goes back to patient-centered care.
Absolutely. So great, guys. We're coming up on the hour now. We're taking some questions. So anything you guys, I'd love to just go around the table. Let's let you go. You all say your piece here and let us know what you guys think. But Robert, I love it. Thank you all for being here. But Robert, you want to start?
I do. Well, first of all, Cosmo, I want to thank you. I want to thank you for inviting us, for recognizing the importance of this, of the need to change the current policy and allowing us to have this stage. Once again, it's this type of opportunity that ultimately is going to allow us to move policy and allow for patients to receive better care and end-of-life care. So thank you so much. And I'll pass it to Jane.
Yeah, I just want to echo the gratitude. I think that we are clearly very passionate about this work. And I think that the biggest plus is that other people know about it. And so this forum and the ability to touch different people, maybe who are a kidney patient themselves or caring for a kidney patient, to know that there is choice. I just appreciate this opportunity to move this mission forward. So thank you for having us.
Thanks.
I just want to say once again, thank you. And thank you, Robert and Jane, for the opportunity. Thank you for your your life's mission and answering the call, because it's life-changing. And I just hope that anyone who is caring for a patient who may be in the ending stages of renal failure, that you advocate for your family member to participate in a concurrent care program, because it definitely provides you the support to make one of the roughest times more enjoyable and easier to navigate through.
Awesome. Well, I think the biggest thing to take away is, I think when people think of innovation, they don't have to think of something grandiose or shiny or something like brand new. Sometimes it's just a new process. And I think there's so many processes in nephrology that are just bad, to be honest with you. Like the way we navigate patient care is terrible sometimes. And I think what you guys have put together here is amazing. Like I've numerous times walked through a dialysis unit and go, what am I doing? Like, what am I doing? Like, who cares about this PTH on this patient? Like, it means nothing. And so I'm just glad you guys are out there doing this. And I hope to see this in some sort of dialysis unit near me one day, and maybe offer those services to a dialysis patient I know as well. So thank you guys so much. And guys, keep those questions coming, and hopefully we can answer them along the way. Okay. Have a wonderful night, guys. Okay.